All right, thank you for the introduction. So we're going to talk mainly about MR in this talk. I know that we have an ultrasound talk to follow, so we'll have an opportunity to learn more about that there. We'll touch a little bit on CT, but I think that we all recognize that MR is being widely and more commonly utilized for evaluation in these patients for various reasons. So most of this is going to be centered on MR, but some of the principles can also apply to CT. These are my disclosures. So let's define the examination, MR enterography. So all the enterographies regarding whether it's MR or CT enterography basically mean that we're giving the patient a large volume of oral contrast with the goal of uniform distension of the small bowel. And of course, the beauty of both MR and CT is not only do we get to evaluate the bowel lumen in this way, but we also get to evaluate what's happening in the wall of the bowel as well as outside of the wall of the bowel. So kind of combining the strengths of all these different techniques and features. A couple of things that we use enterography for now, primarily inflammatory bowel disease. We do a fair amount of evaluation for occult or obscure gastrointestinal bleeding with the idea that we're trying to evaluate for a suspected small bowel tumor. Diffuse bowel disease, not as commonly used, as well as intermittent small bowel obstruction. That's also been kind of hit or miss as well as far as the success of using enterography in that setting, but really focusing most of the utilization of this type of examination for those top 3 indications these days. So let me tell you a little bit about MR enterography before we kind of dive into what we like to look for and see. I think that the best instruction that the patient can get is from you guys, because they can't walk in and not have any idea of what's going to be expected of them for this type of examination. Many of these patients may have had just routine, regular CT examinations in the past. They think they can walk in and have this done. This is a far more involved examination. The patients need to have clear liquids after midnight. They'll have the NPO for about 2 hours prior to the examination. And a lot of this is in an effort to decrease the amount of particulate matter as well as things that can cause susceptibility artifact within the colon. In Europe, they more commonly will do a colon preparation because sometimes they do the MR enterography in combination with an MR colonography, not that commonly used in the United States in the absence of a clinical trial of some sort. There are also some people that advocate for a low manganese diet, which is basically because manganese is very bright on our T1 weighted imaging and so therefore can be somewhat distracting and decrease our sensitivity for enhancement abnormalities in the bowel wall. Personally, I'm not a fan because chocolate has a lot of manganese and I wouldn't be able to eat chocolate for like a week before the study, so not going to happen. All right. The oral contrast that we give, it's a large volume of contrast, and it's not just water. It's usually contrast mixed with some sort of large molecule in order to maintain its presence within the bowel lumen, because as you know, we're fighting this battle against the bowel doing its job, which is absorbing the fluid, right? So we want to make sure that the fluid gets to the terminal ileum ideally in our examination, which requires not just volume, but also timing. So most protocols require the administration of anywhere between 1.5 to 2 liters of contrast, usually starting anywhere between 40 to 30 minutes prior to the table time for that examination. And we give it an aliquots of 500 mils. First one at an hour, next at 40 minutes, next at 20 minutes. And then on the table, we give them water because once again, we're going to be imaging them right after that last aliquot. And so there's not an issue of rapid absorption because that water's still going to be in the bowel at the time that we're imaging since it's mostly there for distension of the stomach through the proximal jejunum at that point. So, I mean, I think this can be somewhat overwhelming, but, you know, there's people out there that drink like a double gulp of Coke in the morning. So, I mean, if you want to put it in that sort of context, that it's, you know, it's a lot of fluid, but we want to engage the patient from the moment that you tell them they're going to be getting this examination to the moment they're coming to our reading area, to our waiting area, and let them know we're doing this. This is a team effort. We're going to do this together. We're going to support you as best as you can when you're trying to ingest this quantity of contrast. Now, we do want to know up front sometimes if the patients have an abnormal amount of bowel, also the patients who may have an ileostomy, because we can reduce the amount of contrast we give those patients in those scenarios, because often we end up with like an imaging of a bag full of oral contrast outside the patient because it's already all gotten through the small bowel there. So it's important for you to let us know if there's less bowel to work with. That means the patient can come in a little bit later and has to ingest slightly less contrast. So what are we doing, going through all this effort for? Well, we want to obtain uniform distension of the entire small bowel because having areas that are collapsed makes our job a lot more challenging. So for an example, in this setting, this is the exact same location, the exact same loop of bowel. Images obtained within like couple of minutes of each other, and you'll notice that this looks like an abnormal segment of bowel, but it's perfectly normal when we see the fluid going through this segment of bowel through an area of peristalsis. And so MRI enterography does afford us the ability to look at the same loop of bowel over and over and over again over the course of the examination during all these different sequences. So as a radiologist, we always want to look to see, does this loop of bowel look abnormal on every single sequence? Because if it's not a fixed abnormality, it's not a true abnormality. But in order to avoid more pitfalls, more distractions, more time spent trying to evaluate loops of bowel that aren't truly thickened, we want to achieve that uniform distension. Not only does it look sometimes like it's abnormally thickened due to poor distension, it can actually look like it's enhancing abnormally. These are two sequences that are obtained within a minute of each other as well after contrast administration. And this loop of bowel is exactly the same as this loop of bowel. That is the exact same loop of bowel. And here, it catches your eye. It makes you think, well, maybe that's hyper-enhancing. Well, it's actually not. It's an artifact brought on by the fact that the bowel is collapsed when we were obtaining this set of images as opposed to this set of images. So once again, really important to ideally get that uniform distension. In addition to giving a large volume of oral contrast, right before we start imaging, we'll usually give people some spasmolytics. In the United States, we use glucagon. In Europe, they use buscopan. This is actually an area of controversy with regards to inflammatory bowel disease images as to how necessary it is to give this, as well as the method of administration. Some places don't give the glucagon at all, primarily as a matter of convenience because it usually will require like a presence of a nurse or a radiologist in order to administer that medication. In California, technologists can't give glucagon to a patient because that is a drug that they would be giving the patient. As well, and patients do sometimes experience some nausea associated with the administration of this drug as well. So there are drawbacks to it. I'm pro-glucagon, and I'm also pro-IV glucagon because studies have shown that there is a rapid, more reliable onset of the spasmolysis when it's given IV, and we give it in a split dose due to the length of the examination because the studies can be over half an hour sometimes. And this is why we do this. This patient actually ended up getting the same imaging sequence both prior and following the glucagon administration. And you can see all these areas of fluffy dark signal within the bowel lumen due to dephasing from peristalsis ongoing at the time of imaging. You can see how distracting that can be compared to the exact same patient, just a few moments later following the administration of glucagon. The bowel lumen is nice and clean. We're not distracted by all this stuff that's showing up in the lumen of the bowel. Really can better appreciate the full pattern and be more sensitive to the detection of abnormalities. And this is just an example here. Sometimes you'll be looking at these MRI enterographies and you're like, why are there so many sequences? Well, there are subtle differences and there's reasons we get sometimes very similar appearing sequences. This is a SSFSE, a steady state, what you might see as kind of a haste image, perhaps depending on your vendor. And this is an SSFP. They look very similar in that the contents of the bowel lumen is bright. But the SSFP is usually immune to flow artifacts. And so if you see something in the lumen on an SSFP, it is a true object within the lumen, be it soft tissue, be it ingested material or something else, as opposed to the SSFSE, which is which is also another rapid T2 weighted sequence, but is prone to artifacts like this. I am also a big fan of prone positioning in these patients, and once again, this is something we just need to work together with the patient. Some patients just cannot lie on their stomach for 30 minutes, and that's fine. It's better to image them on their back and allow them to be comfortable and able to do the breath holds as opposed to pressuring them to try to make them get this imaging done in the prone. But why do we even try to do prone imaging? Well, many of our sequences are obtained in the coronal plane for MR enterography, meaning we're obtaining slices sort of in this direction. And you can see in this example, this is the same patient, same day, lying on their back, lying on their stomach. And the patient's AP diameter is markedly reduced when they're lying on their stomach. And so that means we either have less slices that we have to obtain while we're doing the MR in the coronal plane, meaning the patient doesn't have to hold their breath for as long, or we can use the same breath hold that it would take to get cover this whole area of anatomy, but get thinner slices now instead. The MR is always constantly this set of trade-offs between spatial resolution and imaging time, trying to work within the constraints of whatever motion is happening within the patient or breathing artifact. And so this allows us to cover the same degree of anatomy, but in a shorter degree of time or at a thinner slice thickness. So this is the enterography protocol that we currently use at UCSD. Multiple, very fast sequences that are obtained, many of which in the coronal plane in particular. Our post-contrast imaging is done in the coronal plane, but we do some axial imaging with fat sat as well as without fat saturation to increase our sensitivity to the presence of edema, both within the mesentery and the bowel wall. Spasmolytics are given at 2 times during the examination, so it's a split-dose glucagon protocol. Total table time anywhere from 30 to 45 minutes. Most patients are okay with staying on the table the whole time. We'll have the occasional patient who needs to get up to use the bathroom because the oral contrast agent that we use does go through the bowel quickly, and once again, it is a large volume. And this is another thing that's good to tell your patients. You wouldn't want your patient coming in to get an enterography and then planning to sit in a car for 4 hours driving to Arizona or something, because that's not going to end well. They need to have access to a bathroom and be aware that that's going to may be an issue. There may be some cramping involved as well. So 30 to 45 minutes for an MR enterography. CT enterography, as you guys know, much faster, less than 5 minutes. It's an iodinated contrast examination. For inflammatory bowel disease, we obtain a single phase that's different from when we're looking for a tumor, in which case usually we'll do 2 phases. Very, very fast examination. And CT always affords us, beautiful superior spatial resolution because most of our scanners are acquiring images at 0.625 millimeters these days, meaning that you can take that examination and reconstruct it in any plane that you like afterwards, and to make it lay out the bowel beautifully and to best describe this anatomy. You can see here an area of thickening here in the terminal ileum, nicely demonstrated. We can look at it in any plane that we desire. Of course, there's a reason that MR has supplanted CT enterography, and part of it is, radiation, right? Every time you scan a patient with CT, you're going to be exposing that patient towards radiation. The other thing is that a CT enterography requires the use of intravenous contrast, and there's actually a growing movement to try to remove the intravenous contrast component for MR enterography examinations for several reasons, but we do have the option of doing an MR enterography without IV contrast. We don't have that option with a CT enterography. It's got to be done with contrast. But this is kind of the last time I'm going to speak specifically about CT, because honestly, the best utilization of CT in patients with inflammatory bowel disease from the radiologist's perspective is the patient who comes in with an acute issue, coming in through the ER, getting an acute hospitalization, in which case you don't need to do an enterography. Just do a CT with contrast, because we'll be able to find the obstruction, we'll be able to find the abscess, we'll be able to find the fistula, without the need of putting the patient through drinking that large quantity of oral contrast, which in patients who are acutely ill is also not a good way to treat our patients sometimes. So anyway, all right, so we'll swing back now to MR enterography. And let's talk about why we do enterographies. Well, one of the biggest advantages of MR enterography as opposed to endoscopy, for example, is that we can look at the areas of the bowel that you guys can't get to, or at least you guys can't get to very easily, right? So an enterography is a far less invasive procedure than, for example, a double balloon or push enteroscopy, and so therefore it lends itself far more easily for utilization as a surveillance tool, right? We can do this repeatedly because it's not as a big deal, not as involved for the patients. While we're doing that, though, what are we looking for? And a lot of what we've focused on in the past is to evaluate the degree of activity. You want to be able to identify areas that look like active inflammation, areas that suggest stenosis, or perhaps the patient has quiescent or absent disease. As I mentioned earlier, one of the advantages of cross-sectional imaging is that we can also see beyond the wall of the bowel, right? We can see those ulcers, those sinus tracts, those fistulas, and the occasional abscess that may have developed outside the bowel. Another advantage to MR enterography is that we can also look at the length and location of every site of involvement, right? We can look at any part of the jejunum, any part of the ileum, and tell you exactly how many sites of disease they are and how long all of those segments may be in an increasingly quantitative manner as we see with improving technology. So, I mean, these are the tools that we've had for monitoring activity and response. And, I think that imaging has started playing a much larger role in your armamentarium for looking at these patients. We used to rely predominantly on symptoms. Then, of course, have been using endoscopy as the gold standard. But now we can also use imaging. And we're looking to see if we can make the diagnosis of inflammatory bowel disease as well as looking at the current degree of activity. But response, that is something that's been kind of more on the forefront recently with regards to research. And so now we're looking more towards how can we use imaging in order to be able to quantify transmural activity. Once again, that's an additive value to whatever you guys see on endoscopy, with the goal of, per our STRIDE 2 recommendations, is to treat to target. Treat to the point that we can start seeing transmural healing, transmural resolution of disease. So let's take a couple of examples of kind of what we're looking at on these images. So this is a classic example of acute inflammation in the terminal ileum. So this is our segment of bowel here. This is a post-contrast T1 weighted image, and you can see there's marked thickening of the bowel wall. There's enhancement of that inner portion of the layer of the bowel wall there compared to the other loops of bowel around it. You also see here on our SSFP image that there's mesenteric, proliferation here, right? Because you can see how this is the bowel wall and its lumen, and see how separated it is from all the other loops of bowel, right? So that tells us that the mesentery has been inflamed and is full and bulky in this area, separating out this loop of bowel from the adjacent loops of bowel. We're also seeing engorgement of the vasa recta, all these like little striations there. Those are engorged mesenteric vessels. All of these things telling us that there is acute inflammation, and it's probably in the setting of chronic inflammation, right? Because we've got that mesenteric proliferation. So we do a lot of what we call T2 weighted imaging, which is usually where you see the contents of the bowel bring bright. So all our fluid-filled structures are going to be bright on these imaging sequences because we're looking to see if we can find that submucosal T2 signal, which is a highly specific finding of inflammation for us. This is another example here where you can see this is the lumen of the terminal ileum here. This is one side of the wall. That's the other side of the wall. Like you'd think that there's actually 3 loops of bowel side by side here, but no. This is all edema and thickening of the bowel wall here and here. And we like to apply fat saturation because it increases our sensitivity to that presence of edema. So we look at some cross-section axial images in that same location here. This is the bowel wall, small lumen inside, marked thickening that is bright on our T2 weighted as well as fat saturated imaging. And in this example here, you can also see that there's bright signal outside of the bowel wall. And we know now that increased mesenteric T2 signal tells us that there's edema in the adjacent mesentery, which also suggests transmural inflammation in that setting. Here's another example of a long segment of inflammation involving the terminal ileum here. You can see the marked bowel wall thickening, the marked hyper-enhancement relative to the other loops of bowel. And this is an opportunity for me to tell you about how the length, being able to tell precisely where the disease starts and ends, is a great tool and characteristic of enterography because we can follow that length of disease, and it has been shown that that is an early responsive parameter for treatment. So if nothing else, if the disease looks just as bad, but the length has decreased from one exam to the next, then that can be taken as a sign that the treatment is going in the right direction. Obviously, if it gets longer, then we perhaps need to think about how we want to change our treatment. But it has been shown, and I think it will be increasingly shown in the future, that it is a very responsive parameter. And so this is something that we try to provide on our enterography examinations, is kind of an estimate of the length of disease. And I don't normally get too into the weeds as to making sure it's a curved planar reformat and making sure it's precise to within 1 millimeter. But within 5 centimeters or so is usually we're aiming for that area, and we usually see that degree of change from one exam to the next often. Talking a little bit about diffusion-weighted imaging, I think there's been a lot of focus on the use of diffusion-weighted imaging, particularly as a substitute, perhaps, to contrast-enhanced imaging. The sensitivity of DWI is actually quite good. It's greater than 80% for the detection of active inflammation. We do have some fair number of false positive. They most often occur in the sigmoid colon. For some reason, the sigmoid colon looks kind of brighter on diffusion-weighted imaging than it normally we would expect it to compared to the rest of the bowel. You have to make sure that you're using gradients that are sufficiently strong. So you need to have a strong gradient. This is at B1000, and you can see how between the B500 and the B1000, all these other distractions kind of fall away, and we can really see these areas that are truly representative of restricted diffusion once we get up to a high enough gradient. There is some effort looking to see if we can have some sort of quantitative assessment of our diffusion in the manner of ADC, looking to see if we can set up ADC cutoff values between saying, whether something's active disease or not. Honestly, ADC has troubles with reproducibility from one magnet to the next, so unless you're imaging the patient on the exact same magnet every single time, it may not be particularly helpful, and it also has shown that it's got lower degree of accuracy just using the ADC number than Maria, for example, for responsiveness. Looking to see where the strictures are and how bad they are is also another advantage of enterography. And we've actually started to coming together in the radiology world about how to define a stricture, like what do we mean when we say that there is a stricture? And these criteria have been the 3 criteria that have recently been proposed as our, what we should be coalescing around. A wall thickness of greater than 3 millimeters, luminal narrowing greater than 50%, and pre-stenotic dilation of greater than 3 centimeters. Now that last bit I think is also, it can be kind of a hit or miss on that one depending on how much, distension that there may be in the upstream bowel. Perhaps the patient hasn't had a lot to have recently, or perhaps had an NG tube recently. They may be a little bit more decompressed. So I think that one's a little bit hit or miss with regards to whether we require it to be at least 3 centimeters. If it's like 2.5 centimeters and it's still far different from the downstream bowel, then I think we could still consider that area a stricture. And this is an example here of a patient who has a stricture here in the small bowel in the anterior abdomen. You can see here on our T2 weighted imaging with fat saturation that there is edema within the bowel wall here. There's marked hyperenhancement relative to the other loops of bowel. There's certainly luminal narrowing here. The wall is definitely bigger than 3 millimeters, and the upstream bowel did get up greater than 3 centimeters. And then this is also an example of what this looks like on the diffusion weighted imaging. And currently in my practice, I use diffusion weighted imaging predominantly as a conspicuity marker. Like if I look at the study and if I see something abnormal in the diffusion, then I'm going to go back and look at all the other sequences to see if there's truly something that matches up as an abnormality in that area with regards to edema or hyperenhancement. Here's another example of a stricture, and this one looks different, right? It still meets our criteria. It's still got a wall thickness of greater than 3 millimeters. It's got marked luminal narrowing, right? Look at this loops of dilated bowel, both upstream and downstream to this. It's demonstrating not just the luminal narrowing, but also that dilation. But you'll notice this one looks a little different. It doesn't really have that, really in-your-face restriction on the diffusion-weighted imaging. Doesn't have much in the way of T2 signal here to suggest edema. So this is probably one that's not active right now, right? So this is probably predominantly a fibrotic stricture or something that is not an ongoing area of inflammation currently for this patient. Doesn't mean they're not symptomatic from it, but it's not ongoing. Looking at, and so now we're starting to go into this, discussion about how can we as radiologists help you guys distinguish between things that are predominantly fibrotic as opposed to those things that are predominantly an active inflammatory situation. And one of the things that's been looked at is to evaluate for progressive enhancement. There's a group led by Dr. Remola in Spain, and they were looking to show that if you look at how much the bowel enhances at a 70-second time point and then look again at that segment at 7 minutes, if you have a 24% increase in the amount of enhancement in that portion of bowel, that is suggestive of severe fibrosis. And so this is starting to add to this growing body of literature that perhaps it's not so much the mural stratification that many of us have focused on, that layering in the bowel wall, but more so, does the contrast slowly accumulate in those spaces that would suggest that there is underlying fibrotic material within the bowel wall? So I think we're definitely going to have more to come on this. I think that there's a couple of other papers that have shown that this is not quite as reliable, but I think that I think there's a lot of ongoing research, and I think we'll learn more about this soon. And then ulcerations. Certainly this is something you guys can see in endoscopy. We can also see, how far they extend and whether they communicate with other loops of bowel. This is a nice example here of an ulcer here in the terminal ileum. You can see that little outpouching, a lot of enhancement surrounding that area of inflammation. Another example here in the sigmoid colon, where you can see the little divots, like little bites that have been taken out of that luminal side of the wall there. It's showing you those ulcers or little pockets of fluid even within the bowel wall. And the more you look, the more you can find. And this is actually sometimes can be a relatively subtle finding from the radiologist standpoint, looking for that inner layer of mural irregularity. We've been notoriously, I think, undercalling ulcerations on imaging. And I think that, hopefully as radiologists become more and more comfortable and a little bit more and more rigorous on their evaluations, the examinations, hopefully we'll have increasing sensitivity for these. And just a couple more examples here, kind of showing you how, we can see these long swaths of involvement of small bowel disease. Here, a lot of the ileum here involved in this patient, where you see there's some areas of edema actually in the wall, but then there's other areas where you see the mesenteric proliferation, but not much in the way of bowel thickening. So a mixture of different degrees of activity likely present in this patient. I've been talking a lot about the small bowel, but MR is great for evaluation of the colon, particularly if it isn't too full of poop. You can see here some thickening of the colonic wall and some hyperenhancement there telling us that there's inflammation in the colon. Another example of inflammation here of the colon. And another example here now of some chronic stricturing disease here, multifocal strictures, multiple segments of dilation, both within the whole segment of diseased bowel as well as upstream to it. And, for example, for this patient, you can see that there's actually, if you look at multiple slices, there's actually asymmetric wall thickening along the mesenteric side of this loop of bowel. And so we would consider this segment to be diseased all the way from here all the way up to the ileocecal valve. So very long segment of disease, and you could imagine how challenging it would be to try to evaluate that endoscopically. So I've been telling you a little bit about what we look for on imaging, but how can we quantify it? How can we give you guys tools in order to assess the true responsiveness of your treatments? And as you can imagine, a lot of people have been very excited about doing a lot of research in this. About at least 20 MR indices have been already published. The ones that have gained the most traction are some of the ones that I've listed here: the Maria, the London score, the Claremont score, the Saylor index, which is predominantly for evaluation of anastomoses, and then the extended London index. You can see that there's a lot of work to be done here. There's a lot of people very interested in having their name on an index. But if we look at kind of the common features for some of these indices, many of them have features that we're evaluating over and over again on these different indices: wall thickening, edema within the wall, as well as the presence or absence of an ulceration. So those are the things we kind of want to focus on, make sure we give you guys information regarding. And you may ask, well, why isn't my radiologist giving me a Maria score on all of my enterographies? This is why. These are painful to calculate and really only well utilized given our current technology in a clinical research setting as opposed to a clinical practice. So for example, to calculate the Maria score, you have to put 3 tiny little regions of interest in the area of most marked enhancement in each segment of bowel. Make sure that you put those little regions of interest in the exact same location on the pre-contrast imaging, and then do this calculation of the signal intensity post-GAD minus the pre-GAD, divided by the pre-GAD, and then multiply that by 100. And then you multiply that by 0.02. This is not fun to do, and it's certainly not something that's automated at this point. The other things that go into this score are wall thickness, mural edema, as well as ulceration. So for example, in this patient, this person's segmental score would come out to be at 29, which is well above the threshold that has been identified when comparison with endoscopic through validation studies to qualify as severe disease. And this is the sensitivity and specificity for Maria for be able to say, bin things into whether it's active or perhaps even severe. So that's the Maria, and you can look at that and say, okay, yeah, that seems kind of painful for someone to do on a regular basis on enterographies. And so people have now put out the S Maria, the simplified Maria. And there's a lot less math involved here, and there's no ROIs that you have to draw. And so now here we're just looking at wall thickness, the presence or absence of edema, the presence or absence of an ulceration, the presence or absence of fat stranding. Much simpler score, same segment of bowel that I was showing you earlier. Now gives a segmental score of 4, which is well above the threshold of 2 for saying that this person has severe active inflammation. This score has also been recently endoscopically validated and has actually been shown to be responsive. It changes following successful treatment. But We didn't stop there now. So now there's the modified S-Maria. And the one thing that you'll notice here that's a little bit different is they've added diffusion-weighted imaging to this scoring system. And now there's a slightly subjective score here. No diffusion-weighted imaging, restrict high signal, mild or moderate versus high. This one is, if we use that, once again, the same segment of bowel I've shown you in the prior examinations, you can see there's actually a lot of signal here on the diffusion-weighted imaging. This guy gets a segmental score of 4, which is the exact same segmental score we got with the S-Maria and this exact same segment of bowel. So whether you want to use diffusion-weighted imaging, perhaps particularly those patients that maybe can't get intravenous contrast, that certainly would be a tool for your armamentarium. This one also has been endoscopically validated, but it does have limited sensitivity for penetrating complications. You'll notice that ulcer's not in here, right? And I really make a big deal of ulcerations. I think that you guys do too. And so we're going to have to see how well this, how useful this modified Maria would be. So what do we actually use with regards to our reporting systems? And so there were some consensus recommendations that came out in conjunction with the Gastroenterology Society and Society of Abdominal Radiology, and this was published in Radiology in 2018. I think it was also, a version of it was also published in Gastroenterology. And it talked about what we as radiologists need to be including in all our reports to give to you guys. And so there's kind of a few, like 3 or 4 separate elements that we recommend that people include. Is there active inflammation? If so, where? And how long is it? Is there luminal narrowing? If so, is there upstream dilation? Right? So it's either no luminal narrowing, you can have bowel wall thickening without luminal narrowing, or it's narrowing, and remember we're talking about greater than 50% narrowing, or if there's dilation upstream. And then the element is there penetrating disease? Is there an abscess? And also importantly is, what is the relationship of that penetrating disease to the stricture, right? Because, if we've got a stricture downstream of that area penetrating disease, and then it's just not going to help things out. And so we want to give you those anatomic relationships as well. But now we're starting to do kind of like radiology 2.0, right? So now we want to tell you even more about this. Now let's talk about responsiveness. And so what changes can we say are happening from one exam to the next? Can we say that there's transmural remission? And the definition of transmural remission on imaging is a controversial one. Like, does it have to be an absolutely normal looking bowel, or is it okay if we just say it's almost completely normal? Where do we draw that line? Once again, the length of involvement is something that we really should be providing to you guys in our reports, the extent of disease. Or is it stable? Or is it progressed, in which case we're saying that there's increased evidence of increasing inflammation, increased length of involvement, or perhaps new complications have developed. And this is the sort of thing that we like to see. We like to see these things line up here, right? So endoscopic assessment here, lots of inflammation. We see that large, thickened segment of colon, a lot of inflammation enhancement associated with it. 10 months of treatment later, now we see that there is really flattening of a lot of that inflammation here in the colon, and the wall has also gotten a lot thinner here. And then what do we do, though, when endoscopy and imaging don't seem to line up? And this is an area of growing interest as well. This study that came out in Journal of Crohn's Colitis was looking at the relationship between ileoscopies and enterography studies. So, for example, in this case, in this study, 88 patients that they looked at had a negative ileoscopy and biopsies. The biopsies were negative too, but the enterography was positive. Where was it? How was it positive? Well, a lot of them had proximal small bowel inflammation. Some of them had strictures that were seen only on imaging, and some of them also even had fistulas. So of those patients, when we had a discrepancy between the endoscopic assessment and path assessment, but the imaging, 67% of those actually subsequently progressed to worsening disease. So it's telling us that we should be adding this information together as opposed to discarding it when it doesn't make sense with each other. 50% had a radiologic response that got better over time, and 18% were stable. And looking at those that had negative ileoscopy, but the biopsy ended up being positive, and the enterography had positive, those also had a significant amount of progression in disease in the future as well. So looking to see how we can combine these different tools, looking to see how we can combine these different modalities. Now, I think I'm running a little bit over, but I just want to give you a sense of where we're going to be going in the future. I think that we're going to get a lot of improvements if we have combining different modalities, PET, perhaps those that are targeted towards fibroblasts, and seeing if we can help once again get that holy grail in our mind of distinguishing between fibrotic versus mixed or acute disease, as well as the application of automated quantitative assessments, utilizing artificial intelligence as necessary in order to make these measurements far easier for our day-to-day practicing radiologists. Length of disease, wall thickness, ADC, quantifying the degree of peristalsis, quantifying, doing texture analysis, and qualifying elastography. And so I'm going to end here with a proposed algorithm that was put out by Diagnostics recently about, how do we use endoscopy and imaging together? And kind of focusing on the ones where they don't seem to quite jive. So if there's an active disease in the colonoscopy and a normal MR enterography, then colonoscopy maybe is probably the best tool for that patient. But for example, inactive disease on colonoscopy, but an abnormal MR enterography, maybe we should do enterography in those patients, and perhaps tailoring our follow-up based on how well these tools work together on any given patient. And I think that hopefully as we bring these modalities together, bring our different specialties together, I think we can hopefully combine it for the best of both worlds. All right, thank you for your attention.